Good evening, ladies and gentlemen, my dear doctor. Today I am going to talk about immunotherapy era in head and neck cancer. Okay, you can see this beautiful eco-tourism destination with cool weather and green hills. This is called Ella. You can enjoy this one your life. Okay, these are my objectives. First of all, I want to say what is the current management in head and neck cancer and what is the rationale in adding immunotherapy to radiotherapy. And I want to discuss few key trials and immunotherapy in perioperative setting with operable head and neck cancer and identify where the immunotherapy fits now and near future. For which cancer we are going to talk about? I want to talk about head and neck squamous cell carcinoma. That include oral cavity, oropharynx, especially human papillomavirus positive subtype, and laryngeal carcinoma and hypopharynx. Okay, what is the current standard management? Yes, you know everyone say definitive concurrent chemoradiotherapy with high dose cisplatin or weekly schedule 40 milligram per square meter schedule. This remains the standard for fit patients with head and neck advanced carcinoma. In addition to that, after surgery, especially in oral cavity, we plan for adjuvant radiotherapy or adjuvant concurrent radiotherapy with cisplatin who are positive for margin and extracapsular extension. Again, there's a place for neoadjuvant chemotherapy for downstage the disease or to reduce distant metastatic in advanced head and neck cancer, but it overall survival benefit is varies. Okay, effect of radiotherapy. So everyone will say, what is, if I ask someone what is the effect of radiotherapy, they say there's a direct effect on DNA. It can damage double strand or single strand, so cell death. But in addition to that, radiotherapy have another effect. It can activate immunity. One thing is called immunogenic cell death. The died tumor cells, they release signals that is called DAMPs. They activate T cells. Same time, the tumor itself, irradiated tumor itself acts as an in situ vaccine. They release mutated protein, act as antigen. This antigen captures by dendritic cells and migrate to lymph node. In there, they present to T cell and T cell trigger. There's another concept called abscorbal effect. The surrounding non-irradiated cells, cancer cells, also regression because of this T cell activation. So radiotherapy, they don't give only DNA effect, it can activate immune system. Okay. This picture illustrates irradiated cell release, you can see red color antigen. This antigen captured by dendritic cell and present to T cell in lymph node. The activated T cell have two effects. One thing is abscorbal effect, and other effect is it act on tumor. So PD-1 is a protein on T cell. PDL1 is protein on tumor cell. When PD-1 and PDL1 combine, they cannot attack. The T cell cannot attack to tumor cell. So immunotherapy will help to remove this block. So there is a hypothesis, radiotherapy can induce T cell, immunotherapy can remove this bond. So this want to highlight this hypothesis. So this is wonderful creation in my country. So before Jesus' birth, showing the great engineering and skill in ancient Sri Lanka. This is a Ruan Valley Saya. Okay. So we'll go for these two trials regarding concurrent chemoradiotherapy with immunotherapy. One is locally advanced head and neck cancer. The experimental arm, they treated with Pembro. Pembro with concurrent chemoradiotherapy. Usually we give cisplatin-based chemotherapy with Pembro. And control arm, we check with placebo with concurrent chemoradiotherapy. We'll see the results. This phase 3 trial, most of them are oropharyngeal carcinoma, some of them are human papillomavirus positive. So experimental arm, Pembro plus cisplatin plus IMRT, control arm with concurrent chemoradiotherapy with placebo. So you see small difference in survival curve, event-free survival, but that is not statistically significant. And even overall survival is so not different. So Pembro, in addition to that, Pembro is give a lot of side effects. So this fail. Pembro in this stage is fail. So Temsulumab adding to chemoradiotherapy not improve survival. So this routinely not recommended. So we'll see another trial. This is called Jotep Pembrorate. We use Pembro with radiotherapy versus cetuximab with radiotherapy. You know why we use cetuximab? The patients who are ineligible for cisplatin, for squamous cell head and neck cancer. Because of renal insufficient or any contraindications, cetuximab can replace cisplatin. So in this trial, they compare cetuximab was Pembro. So you can see the results. Again, Pembro failed. Pembro with radiotherapy, control arm is cetuximab with radiotherapy. They give similar effect, similar outcome. Okay, so local control are similar. Progression fever is also similar. Overall survival no difference. But important point in here, when you assess the toxicity, Pembro arm is less toxicity. So, in my experience in my country, when you try with cetuximab, we get a lot of reactions. So Pembro plus radiotherapy, even they didn't show any benefit compared to cetuximab. This is a good alternative to cetuximab. It's give less toxic and better toleration. So what is the current standard management? So what is the benefit of adding immunotherapy to concurrent chemoradiation? Several phase 3 trial, one thing I told, Keynote 412, that didn't show any benefit. Juvenile head and neck, 100, that's avelumab plus chemoradiotherapy, that was abandoned because poor response. So final analysis was no cervical benefit adding chemotherapy, adding immunotherapy to concurrent chemoradiotherapy, so that is not recommended. But keep this in your mind, if patients with ineligible cisplatin population, Pembro is a good alternative and less toxic and better tolerated. Okay. This is our memories, Sangha, Sanat, and Arjuna. Okay. We'll go for this case. This is a young fellow, medically fit, non-smoker. He came with 5 months right side lateral trunk lesion. So biopsy say grade 2 squamous cell carcinoma. This PDL1 is positive. CT scan T3N1 disease. Okay. What are the operable cancer in head and neck? Most of the time we refer the patient for surgeon for oral cavity lesion. In addition to that, human papilloma positive or negative tonsil or base of tongue cancer or selective laryngeal cancer also possible for surgery. But usually we manage them with radical chemoradiotherapy because considering organ preservation. This patient usually be managed with wide local excision followed by adjuvant radiotherapy or adjuvant chemoradiotherapy according to risk. But now 2 immunotherapy trials were published regarding operable cancer. We'll see that too. This is number 1, Keynote 689. The population is adult polar resectable cancer in head and neck squamous cell carcinoma. Most of them are oral cavity with good performance. they have to undergo PDL1 expression or not, or human papillomavirus positivity. The total population, 714, randomized 1:1 ratio. In experimental arm, neoadjuvant 2 cycle of Pembro followed by surgery. And after that, adjuvant Pembro plus radiotherapy and continue Pembro for another 12 cycles. That's the experimental arm. So neoadjuvant base and adjuvant base is perioperative Pembro. The control arm has a usual base surgery followed by adjuvant radiotherapy. So you can see the difference. It's a positive trial. So event-free survival, 51 months in Pembro group and 30 months in normal system. And side effects also not different so much. So this benefit is observed only in PDL1 positive subgroup. And magnitude also increase with PDL1 level is very high. And the data is still immature because now we are in 2025. So overall survey data still we can't comment. Important point is we can see pathological response. So the level will affect, PDL1 level is effect. If CPS score less than 1, minimal effect. If it is more than 1, there's a good effect. But if it is more than 10, there's a marvelous effect. So another trial is called Neo post-op study. So this inclusion criteria, all are resected people. The initial trial, unresected, operable patient. In here, resected is squamous cell carcinoma. This would be most of the oral cavity. But after resected, you have to see some risk factors. The patients who are with magnitude, large number of lymph nodes, who are margins are positive, extranodal extension, these high risk factors. So they do 2 arm with Neo, adjuvant base. Initially that given neoadjuvant and adjuvant base. Here all are given adjuvant base, adjuvant chemoradiotherapy, and Neo continue as adjuvant, which compare with IMRT with cisplatin. Okay, 3 years survival assessment, disease-free survival, and nivolumab group better compared to normal concurrent chemoradiotherapy. Again, the overall survival can't comment here. But toxicities nivolumab group is little higher compared to other one. So this is a comparison, adjuvant trials. Keynote 689, that is resectable cancer in head and neck, squamous cell carcinoma, treated with perioperative Pembro. A Neostop trial, resected carcinoma who have high risk factors at nivolumab in adjuvant base. Most of the time we have given 2, actually we have given 2 cycles, that trial has been given 2 cycles as a major effect on distant recurrence reduction. In Keynote 689, Neostop trial, there's a strong effect on local regional control because we are targeting high-risk people to prevent distant metastatic. Neostop trial, regardless of PDL1, we can use nivolumab, but Keynote trial, PDL1 positivity is mandatory. So, adjuvant trials, these 2 trials are clinically meaningful improvement and marvelous event-free outcome. So adding immunotherapy in perioperative setting and adjuvant. The safety profile will be also acceptable. So these 2 words important. PD1 positive advanced oral cavity. You can use 2 cycles of Pembro to get this response. And patient are high risk resected oral cancer. We can use nivolumab and adjuvant base to target, prevent local recurrence. Okay, what about recurrence and metastatic state? So another true trial, Checkmate 141. So in recurrent and metastatic, here all the population now we non-palliative intent, not amenable to curative intent, but performance are okay. They have been treated with several cycles of platinum-based chemotherapy. Now they are platinum refractory. So experimental arm treated with nivolumab monotherapy. Control arm, they treat with single agent chemotherapy, either cetuximab or docetaxel, whatever the other chemotherapy. And you can see survival benefit. First year overall survival is 35% and 16% in chemotherapy arm. So nivolumab has a more favorable safety profile compared to chemotherapy arm. The trial was actually abandoned because marvelous response with nivolumab. So based on this checkmate 1-4 results, nivolumab was approved as platinum refractory recurrent or metastatic head and neck cancer. So this is a good alternative, the patient with recurrent head and neck cancer. Okay, this is another trial, Keynote 048. This group is previously untreated as a first line head and neck cancer, squamous cell, OLA, recurrent and metastatic. So these patients in experimental arm, they have given pembro as monotherapy. In experimental arm 2, they pembro plus chemotherapy. And control arm, they use extreme trial, cetuximab plus platinum 5F. All the patients are stratified according to PD-L1 positivity, CPS 1, less than 1, more than 1, or more than 20. And all pharyngeal patients, oropharyngeal patients, stratified human papilloma virus positive or negativity. Okay, this is the results. So 5-year overall survival, the pembro graph double compared to chemotherapy. And single agent pembro itself have a marvelous response compared to extreme regimen. Even pembro with chemotherapy also have a more than benefit with extreme chemotherapy. So the differences and the benefit is significant with if your PD-L1 is very high. But both human papilloma virus positivity or negativity didn't show any benefit. All have a same effect. But important point is PD-L1 positive or negative. PD-L1 positive is a strong predictor of this one. Okay. Comparison of these two trials in recurrent and metastatic state. Nivolumab we can use platinum refractory patients, irrespective of PD-L1, and they have a double effect, double response compared to chemotherapy. Keynote 8C, Keynote trial, you can use pembro as a first line, pembro monotherapy or pembro with chemo, but important point is PD-L1 should be positive. The response also very good compared to chemotherapy. So in recurrent and metastatic head and neck cancer, you can use nivolumab in platinum refractory patient, pembro monotherapy or pembro with chemotherapy can use as first line if PD-L1 positive. Okay, please think something about toxicity. Common immunoreactions, hypothyroidism, hepatitis, dermatitis, pneumonitis, and colitis. In addition to that, chemo radiotherapy toxicity also there. So practically, please arrange baseline thyroid function, liver function, and pulmonary assessment, and please refer the patient for supportive care, nutrition, for early. Okay, this is my take-home messages. Concurrent pembro radiotherapy is not yet standard in head and neck cancer. Cisplatin ineligible population, pembro appear good alternative to cetuximab. Even 2 cycles of pembro can downstage operable tumor in head and neck cancer. Nivolumab can use patient with high risk resected head and neck cancer to prevent local recurrence. In recurrent and metastatic stage, pembro can use as first line treatment, nivolumab can use as refractory disease patient. So continuous cisplatin based chemotherapy still is a curative backbone until phase 3 data is mature. Okay, this is Kandy, it's a heritage city, my hospital is there. And tumor radiation remains the backbone immunotherapy is the future partner. Thank you very much.